TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree, Chappell, your host, and we have just wrapped up EBPOM Las Vegas, our very first meeting of 2021. EBPOM, or Evidence-Based Perioperative Medicine, is a multinational organization that's been around for 20 plus years, and joining us today is my co-host, editor-in-chief of TopMedTalk, and founder of EBPOM, Monty Mythen. Hello, Monty. How are you?
I'm good, Desiree. Great to be here.
It is. I'm missing you, buddy. It's been too long.
Well, hang on, we were in Vegas a week ago.
Yeah. Vegas.
Vegas. Well, I was here. You were there, I think.
Yeah.
And we were doing virtual Vegas. I enjoyed that meeting. It was a great format.
Yes, it was. And I urge all of our TopMedTalk listeners, if you haven't had a chance to, you can still go on our site at ebpom.org or live.ebpom.org and actually check out our platform, our meeting platform. It's really cool, Monty. Tell us a little bit more about it.
Well, we're leaving our carbon-friendly conference center, as we're now calling it, which is our platform, which is the route into our various different media opportunities, is going to be running 365 now. So 24/7, 365 days a year. So there'll be new content and accessible archive content there the whole time. So if you go to Vegas On Demand, for example, you'll be able to see the recent meeting.
Yeah, it's awesome. And we are trying it out, I think, this year to offer this to our partners and our friends. If they have different meetings that they want to host, we actually can help them with that, can't we? We
can. We got the Welsh Perioperative Medicine Group. They're doing a special meeting about anemia, and it's going to be coming off our main stage, which for that event will be the Cardiff stage.
Awesome.
And that's in April. April.
Super exciting. So that is a lot to look forward this year, but we really hope that as everyone, starts getting their vaccinations, especially us in healthcare, and maybe the world starts opening up a little bit, that we kind of transition to hybrid meetings.
That's the plan. We're hoping that, I think realistically, we're very, very hopeful the way things are going, with vaccinations and everything else, that we'll have our first hybrid event, which would normally be our London meeting. So the London 2021 meeting, which will be back end of June, early July. We're hoping that we'll have multiple venues around the world. I doubt we're going to be seeing a lot of mass transatlantic long distance traveling, but hopefully you'll have an event where people can come and socialize and chat and watch the various different lectures, and you can get involved in the conversations in your hometown. And I happen to live in London, so I'll be doing it in my hometown, I hope. But I hope we'll be doing it as a community. For our TopMedTalk listeners,
if you're interested in kind of hosting a little fan zone, as Monty likes to call them, let us know.
Do it the way that works for you. So we're going to do some of it, we hope, in our quad at University College London, which is a nice open space. Other people are thinking about going to upstairs at sports bars, and other people are thinking about spa hotels. So I spend a lot of time thinking about spa hotels.
I know,
but
especially right now.
Going to one. Exactly.
All right, Monty. Well, this past year, we never could have kept EBPOM mainly free, almost completely free for the entire year. Thanks for everyone for all their support, but we never could have done that without the support of our partners. And so we really wanted to give them an opportunity to talk to our listeners too and have a great conversation with them. So kind of as part of a new series for TopMedTalk and EBPOM, we're taking this opportunity to hear from them. So it's with great pleasure to introduce a wonderful, wonderful friend of EBPOM and TopMedTalk. And I love it because he's a top contributor to every meeting that we've done. We have Marc Koch, who is president of Somnia. Marc, it is wonderful to have you.
It's wonderful to see you too.
I think the last time that we actually were able to sit down in person and talk was maybe the SPACI meeting, the Perioperative Summit in Florida, like a year and a half ago. It seems like forever.
Yeah, I think so, because that was when they started to close things down right after that. And I remember that was one of the last in-person only meetings, was that meeting. I think you're right. Yeah.
Tell us a little bit more about yourself.
Sure. Well, I'm a board-certified anesthesiologist. I went to medical school at Stony Brook, which is where I grew up. I remember actually the medical school being built up from my treehouse. That's where I ended up going to medical school. And then I went to Yale to do my residency. And I practiced for a couple years, and then I went while I practiced, and I got my MBA, going to school at night for 3 years, Fordham, before they had executive MBAs. And I've been very lucky to serve for almost 25 years as CEO for Somnia. And we went from one person now to close to 1,000 people in close to 20 states in both hospitals, surgery centers, and office-based facilities. And it's been quite a journey. And like most journeys, it involves working with people who care deeply about what they do and how they do it. And both yourself and Monty and Dr. Aronson really have been instrumental in both inspiring and encouraging. And, your example has really been such a big part of my life on a professional and personal basis for many years. And thank you.
Oh, that's wonderful.
If I could, Desiree, Marc, in 25 years, you must have seen some amazing changes in the delivery of healthcare.
Yeah, remarkably so.
Yeah, and it's a very big question to spring upon you. What's excited you most recently? What do you think is going to be our next big paradigm shift? A
lot of what we see now is governed by data. People think that data is the answer, and it's not. And I know I have a quote that Dr. Saul Aronson always tells me, he says, between data and change is reality. And I think that's a very wise sentence. So I think that data will become one of the pivotal and required points to become comfortable with, aware of, know where to get it, how to use it. But then how to instigate change, because knowing that there's a problem doesn't solve it. And that solving it, as Dr. Aronson told me, really is based upon culture, emotion, tradition, making it so people could accomplish it. So I think it's this issue of data, but then using that data most effectively. And that's part of what Dr. Sharma will be sharing with us on the call today. We looked and we saw, based upon the CMS data sets, that patient outcomes were not great. This hospital, which of course I won't mention the name, was in sort of the lowest percentile, if you will, or as we like to put it more politically, an imperfect percentile with regard to patient outcomes. And moreover, we drilled down one step further and saw that the data with regard to avoidable adverse events was significantly an opportunity.
Before you go on, why don't we go ahead and introduce your friends?
Sure. So Dr. Sharma, she's a board-certified anesthesiologist. She's a UCLA-trained anesthesiologist who has a master's in statistics and epidemiology, and she's an acute pain fellowship-trained physician who has been a widely requested, heralded educator, not just on anesthesiology topics, but also on acute pain topics and how acute pain could really improve patient outcomes. And no matter what we do or how we do it, Dr. Sharma always says to me, we always have to look at patient outcomes. And if that's the guiding principle, Dr. Sharma always says, then that's what we have to be aiming for. And she is educator, trainer, and admirer. She's a wonderful person that brings so much to bear in what she does. And have I left anything out, Dr. Sharma?
No, but my head's starting to swell, so I better stop and I'm going to get through the door.
Marc's good at that. Shelley, thank you so much for joining us. I really appreciate you taking the time. So you're based out in LA, so a little bit early for you today.
It is, but I'm going to make one correction. USC trained, not UCLA.
We need to get that one right. Good.
Dr. Sharma's background is just unassailable. She's USC trained in anesthesiology. She did a fellowship in acute pain fellowship in it. And in addition to that, she also has a master's degree in statistics and epidemiology. And she brings all of those experiences to bear in her role of educating clinicians across the country on how to use acute pain to improve patient outcomes.
Fantastic. Shelley, thank you so much for joining us. I know it's super early there in California. No, Marc did a great job of giving us a little bit about your background, but tell us a little bit more about yourself and some of the work that you've been doing recently.
Yeah. Thanks, Desiree. Thanks, Monty. Dr. Koch, obviously that was quite an introduction. I hope I can live up to those expectations. Anyhow, yes, a little bit more about myself. I'm a California native. Don't go anywhere near New York. The snow is not something. I remember the farthest I had traveled was Northern California, and the temperatures plunged once, and I was like, yeah, I got to stay in LA. Anyways, California, born and raised and trained here. I did my training at USC, and also, as Marc mentioned, I have a background in biostatistics and epidemiology, which I think is just a perfect fit for, a position like this. So to fill you guys in, I'm the acute pain service line director for Somnia Anesthesia. And My role and responsibility is to drive change, obviously with outcomes in mind. And, Marc mentioned that we are highlighting during this call one particular practice that, we noticed a lot of the current, before Somnia was involved, when I say current, the outcomes provided us an opportunity to implement and affect change with the use of acute pain and all of the various strategies. We started looking at the data for the facility and, the patient outcomes. We also started to, when Somnia was involved at the facility, we began to talk to our nursing teams, our surgeons, to figure out, some of their issues, concerns. And for me, when I became involved, specifically issues related to acute pain. And, we looked at the quality of all of the acute pain strategies. We looked at the volume of cases. We looked at the services being provided. And we learned that, there was significant opportunity based on the data. So what that means is, there was a significant number of, let's say, orthopedic cases, and the number of acute pain interventions were just not there. And after learning more about the facility, talking to the providers, talking to the nursing team, we learned that, at the facility, there were some events, specifically local anesthetic toxicity events, poor outcomes. Some of the blocks that were being performed just weren't up to par. And it was a little bit disappointing, but again, it presented us with an opportunity to really focus in on how we could improve that. In addition, we looked at the volume of cases, as I mentioned, and the number of acute pain interventions that were being offered to patients. And we found that, what was it, Dr. Koch? I think it was about 1% of available cases. And obviously there's some gray areas with comorbidities and, patients refusing regional anesthesia interventions. But about 1% of those, let's say, orthopedic cases, or I think it was orthopedic cases, were actually getting acute pain interventions. And we were a bit disappointed by that. So when Somnia became involved, we realized this was an opportunity for us to really affect change. And, change is a multidisciplinary and multifactorial process that, allows many different people to come to the table and, bring up not only their concerns, but their goals and objectives. Anyhow,
Shelley, could I ask you, because I'm sure we're going to talk about culture in a while, but did the institution say, we think we need help? Or did you have to say, we think you need help? Because
that's a great question, Monty. And I think it was a little bit of both. I think that was the reason why Somnia was invited to the hospital facility, and they were looking for a partner, somebody who was going to help affect change and be, invested in that, in an outcomes-based approach. And that's where we came in. And, as Dr. Koch very well, he's all about outcomes, all about data. And it's such an honor and pleasure to work with him. And, now that my head's about that big, I'd like to share that. He's so invested in outcomes and data that it really gives us an objective view on how to approach things. Anyhow, again,
because the data is usually one of the ways of overcoming the culture challenge, because that we were touching on it earlier. Culture eats almost everything for breakfast,
exactly,
but it struggles to eat data.
Yeah, and you're spot on with that. It's an excellent point. I'm dealing with another facility where, we are relying solely on data to address the culture change, because culture is, as you mentioned, is it's just
king.
Yeah, exactly. And it can be an uphill battle.
So one thing is, it's really important, when you come into a facility and you take a look at some of the outcome data that you see, it won't be the first or last time you see data that shows tremendous opportunity for improvement. But you always have to bear in mind that somebody else's house, it's somebody else's institution, it's somebody else's operating room. And nobody likes to be told they have an ugly baby. And being able to have that very difficult discussion with somebody is very hard, right? And it requires a very nuanced and politically discussion, because when somebody is sort of not really doing even near what might be a reasonable expectation, how you put that could turn them on or turn them off. And that very first moment that you realize there's an opportunity and the data brings you there is the very time you really have to not say much. Because if you do, and you tell them they have an ugly baby, nobody likes that.
So tell us about that value proposition that you used with this particular facility.
So is the value proposition with the clinicians or with the facility, Desiree? Which one?
Well, let's start with the facility, because I think then we get into culture and talk about the clinicians.
Right. Well, if you start to take a look at some of the CMS data sets, you could see where DRG performance is great, not so great. You could see where CMS incentives or penalties are significant. And when you start to have those discussions and you help them connect the dots through self-enlightenment, that's very helpful. So to explain to them that you're the lowest percentile of fill in the blank, they're going to shut down. Mm-hmm. But if you say, listen, I think your DRG performance just is not the best, and I noticed your complication rates, post-surgical complications are a little bit higher than we might all prefer. What do you think about this idea? What would happen if we started to take a look at doing some develop an acute pain service that takes a look at doing regional anesthesia or starts to put acute pain blocks in, because post-operatively they'll have fewer issues with delirium, fewer issues with prolonged stays, fewer issues with maybe going to the ICU because they had cardiac or pulmonary events. So you begin to connect those dots, but each one of those dots has to be supported by their literature. And when you do that, the bottom line is, if I could be just very brief, if you're able to put in place in our case, an acute pain service, which is much more than a block, it's a service, do you and will you reduce complications? And if so, will those complications lead to fewer ICU stays, fewer length of stay, improved outcomes across the board? Renal, cardiac, pulmonary, pain, you name it. And then that and that alone will lead to better yield with regard to DRGs and hopefully convert a penalty state with regard to CMS over to an incentive state. So that kind of conversation is sort of what has to happen. And again, what you didn't hear me say in that sort of discussion was, this place is terrible. This place is this. It's that. It's focusing on the good and explaining how we can make it even better and letting them come to that conclusion.
This conversation is very U.S. focused. So we're talking a lot about, DRGs or those coding language for, how we get paid based on what type of procedure it is. CMS obviously is our national healthcare system. Monty, did you want to say something?
It's good. Ask both Marc and Shelley really whether they're incentives or penalties, and different payers dress them up in different ways at different times, but it usually the price you get for doing the work varies according to the quality of the work. Do you think they work effectively if they're based on process rather than outcomes?
I think you have to again take a look at what the evidence tells us, and if you start to reward and recognize people for providing the best care that evidence supports, that gets you everything else. And if you focus on letting people do what they do best, the clinicians providing the best clinical care they can based upon the evidence, then that will get you there. We've developed fairly sophisticated pay-for-performance program that rewards and recognizes people, for instance, for quality, for safety, and also for skill development, new skill development and maintenance. So it's not just skills like, being able to play the flute. It is a true evidence-based clinical skill that we know will improve outcomes. And that's what we focus on. And we don't pay people for doing X or Y. We pay them for a yearn to learn and to develop the new skills necessary to promote the best care that the evidence supports. And that's what we focus on.
So that's an individual portfolio or a group portfolio? Because I like the individual incentives.
It's individual.
Yep.
And the reason we do it individual, because we think every individual has to decide and take that initiative. You decide you want to broaden, deepen your skills, in this case, acute pain, because that's something from within. And, maybe you've been inspired by Desiree or yourself or Dr. Aronson, but at the end of the day, they don't do the heavy lifting. You do, and you have to learn it. So I think,
sorry.
Go ahead. I'm sorry. I'll let Dr. Sharma tack on.
I wanted Dr. Koch to give the overall perspective of the pay for performance. And, you're right, Monty, there's an outcome and a process, right? What are we incentivizing for? And I think it's a little bit of both. And the process is such an important element of, delivering, whatever, anesthesia, acute pain care. We are hoping to incentivize for both, right? Obviously, outcomes need to be rewarded, but the process by which it's done. So part of our pay for performance, especially related to acute pain, is everything about quality of the care. So, and though this isn't something, I think everybody's going to do, but, when we are implementing something like this, especially the acute pain segment of the pay for performance, I'm responsible for reviewing all of our providers, medical records and making certain that, we're delivering this quality of care. And, I go through each of these notes and I know these providers by name and I work with them, I talk to them. And we identify, all of the cases that may be outliers, which there weren't many on our last audit of 400 charts or whatever the number was. But we're looking at both and we're incentivizing for both process and outcomes. And we're thrilled because our facility, this particular facility, went from doing, what was it, Dr. Koch, 159 blocks over 2019, and I think over 1,200 in 2020. Wow. And in the Q3 period that I audited for this facility of 2020, we only noticed 2 outliers, and the patients were fine. It just, there were two potential outcomes that could be done better. So, I guess to answer your question, Monty, it's both. We're looking at process and we're rewarding for process to ensure good quality of care, and we're also rewarding for outcomes. And it's a little bit of both.
I mean, that kind of takes us into this next question that I have and that we've touched on earlier is, how do you change culture? Because it is the hardest thing that we do. And I think a lot of it comes probably from what we just talked about. But let's sit on that for a second and look at the value proposition for our clinician.
I think you have to communicate high level goals. And what I would say, even before goals and objectives, there's a vision. And I think you have to say our vision is to have better outcomes through evidence-based practice. And if you set that as a vision, and anything you do and any way you do it has to center around that vision, then that's sort of your mooring. That's your R-squared coefficient. That is keeping you very tightly moored to what you're going to do. And setting that vision is important because then you could say, okay, we're going to have a journal club. We're going to have a workshop. We're going to have a webinar. We're going to give you access to an ultrasound library, where everything you do has to center around that vision. So when you set forth your objectives, i.e., we want to improve some outcome measures in the CMS data sets, when you set forth your goal to go from doing 1%, acute pain encounters to having that go up significantly, whatever it is. And then you start to develop a strategic approach, a tactical plan to do that. But if you follow that process, if you will, that gets you there. And you have to take every part of that seriously. No part is less or more important than the other. Some people think, well, if I get this right, then that'll happen. No, every part's important. And to be thorough, complete, measured, and careful. Even when talking about pay for performance, that could go very wrong very quickly if it's done wrong. We've had some lessons to learn, and what I think it's important just to have that in mind. Dr. Sharma, did I leave anything out that you might want to add to that?
I'm going to just embellish that maybe at the practice level and provide some more details. So for me, especially related to acute pain, I think there's a cool factor, Of course, we're driven by science. Of course, we're driven by data. But I think a lot of people are just yearning for more education and knowledge when it comes to acute pain because of all of this emerging technology, specifically ultrasound. And as our ultrasounds have evolved and, we can see so much more and we've incorporated it into our practices, there's this, and I use this term cool very loosely, but it's interesting, right? It's like, oh, here's a new skill set that I didn't get to learn in my training, or this is something I can incorporate. And I want to know how to do it. And, though we're driven by data and science, and that's our, main objective, I have the fortunate role, I think, of executing these workshops with this quote cool factor of all these skills. And I think that makes it a little bit easier for me personally, because there is such a desire already in the communities that we work with and at our practices. So people already want to join. And those who don't might start to feel this infectious mentality. So we were on a call with this particular hospital system, our team, I want to say a month or two ago, and we were giving them an update on this pay for performance. And there were a couple new providers who had joined the team, and they were just really brimming with enthusiasm. Like, how do I get to be a part of this? And I got some emails. Well, how can I join? And, I want to be able to do some of these things. And, we've incorporated them into the fold with a very thorough, measured process. Because obviously, and for Dr. Koch and myself, we're very cautious, very careful, very measured about, yes, there might be a fun, cool factor, but this is a process and we are very driven by data and science and patient outcomes. So it's not just that, we want to hand someone a needle and it's sticking a needle in someone's neck and walking away. We want to ensure that everything from documentation to consent to making certain that patients are educated, they have the right to refuse an acute pain intervention if they do not wish to have one, to ultrasound use and image and follow-ups, and making certain that patients are getting good care. And it's been a process, as you can tell, and it's just really exciting to see many of our providers start to embrace this change. And it's been a year plus, at least at this facility, and it's exciting to see our providers really just, not only grow the acute pain service, but jump on this bandwagon and hope to be a part of it. So, I'm embellished a little bit, maybe at the practical level, Dr. Koch, but I'll let you jump right in there, either Desiree or Monty.
So Monty.
I'm just going to make a comment. It relates to culture as well. Some of the big change programs I've been involved with at a national level, I've learned that when providers are asked in public why they don't want to change, they usually say they don't believe the data or they don't think there's enough evidence. When they're asked in private, they usually say, I don't have the tools and I don't know how to do it. Mm-hmm. But I'd love to learn. You just have to give me the time and the opportunity to learn. So the resistance is often, look, when I learned to do blocks, it was by sticking needles in until someone said, ouch. Was that right, Marc? I really want to do is I want to learn the new stuff, but I need the time and the tools and let's go at it.
Well, and sorry, I'm just going to add one thing. That's an excellent point, Monty. And, adding to that just a little bit, I'd like to recognize the investment that Somnia has made into their providers by, bringing someone like myself on. And, I used to be a consultant for, a couple different companies, and I would teach across the country. I mean, everywhere from, the East Coast to the West Coast. And, that was wonderful. And it's during one of these chance meetings that I ran into someone that knew Dr. Koch. Anyhow, I'd like to highlight, I think, the vision that Dr. Koch as a CEO has, and he knows, I've told him this, he's recognizing that there needs to be some investment in the providers as acute pain has changed across, I guess the country, across the world, and making certain that this is delivered to all of our providers and we're investing in them and essentially optimizing and investing in patient outcomes, right? That's the goal for Dr. Koch and myself, is ensuring that patients are getting the best care. So that's what drives us every day. Anyhow, sorry, another
No,
long.
I love it. I think it's fantastic. And, I use the word empower a lot, even though that's not a word that we use in our, kind of nomenclature for anesthesia. But I feel like we're empowering our providers to, have the knowledge, have the data in front of them so they feel like they don't have to say, well, I don't have that. I don't know. Like, we want to provide that. So I think it's fantastic, and applaud you guys for all the work that you've done. In the final couple minutes here, we get the question a lot because acute pain service means, very different things to a lot of different people. And so, and I know that this is a trend, as you both have said, throughout the US. What is it? So, Shelley, you go into the small facility. What does this acute pain service look like at that particular facility?
So that's a great question. And I think before I can answer that, I want to give you a little background. So, when we've identified that our practice is functioning at appropriate capacity with the appropriate staff, and many of the initial, transition kinks have been worked out, obviously it's a team approach, but we decide that, it's time for a diligent site visit. Let's start to address acute pain. So that site visit involves, like I've mentioned, a multidisciplinary approach, which, everything from getting feedback from nurses and, some surgeons and really figuring out what's going on at the facility. Anyhow, from there, from the diligent site visit and, observing our clinicians, observing the procedures, looking at the data and taking all this feedback that we've gotten from our nursing teams, our surgeons, from hospital leadership, we began to formulate a plan, and that's our gap, our gap analysis. And it helps us construct a plan about how acute pain can be implemented at a facility. And as you know, each facility is going to be different. A hospital in New York might be doing, primarily orthopedic procedures, whereas one, in the Midwest might be doing, let's say, urologic or OB/GYN procedure. That's their volume of cases. Anyhow, so that allows us to develop a plan and a strategy. From there, we start to address where the gaps are, and that's everything from documentation to education. And we really start to focus in on, okay, if we're going to implement change, we need to have these educational workshops, and they need to focus on these particular interventions and or strategies. As you can imagine, this takes some time. But once we've figured out our plan and implemented some of these strategies, we have these workshops, hands-on workshops, which I myself deliver. And these are typically CME accredited activities. We go to great lengths to make sure that our providers do get credit for this. So, there's no conflict of interest here, but we'd like to ensure that they, benefit from the learning. Anyhow, taking that a step further, we then like to make sure that all of these providers understand the value of follow-up care. And it's not just, making sure that somebody gets a needle placed appropriately and understand the benefits and the risks, and there's indications and contraindications, but it's also that these patients should be followed. As we've done that, our services have grown. So this particular facility, I told you, has not only increased the volume of acute pain interventions, but they've now begun to implement an acute pain service in many ways by placing continuous nerve blocks, placing epidural catheters that can go out onto the or go to the ICU with obviously monitoring, et cetera. And we've started to implement strategies for OB patients with tap blocks. So the service has continued to grow.
Yeah, a lot of people say when they talk about an acute pain service, through the continuum, preoperative, all the way to discharge, and even beyond discharge, if they're going home with, catheters that are in place. Is that what your acute pain service looks like? You guys manage all the way through and kind of take the pain management on as far as anesthesia goes? Like, you'll take calls back and things like that?
Yeah. So that's such an important element of an acute pain service, especially in the follow-up care phase of this. So if a catheter is placed or an epidural is placed, somebody needs to be available. And that's such an important piece of follow-up that I think, you have to work through this with our clinicians. And I've worked with teams across the country. I'm actually in the middle of doing that with one of our teams in Arizona, no, New Mexico right now. And we're implementing a process by which patients get care. So making certain that there is someone available to take their phone calls, to address any issues, because, we are, as you know, Monty and Desiree, we are the experts when it comes to everything related to local anesthetics, these interventions, and we need to be the ones answering those questions, because if something were to go wrong or if there is a concern, we need to be the ones that are notified or at least on top of those issues and notified immediately. So it's a culture change, I think, for a lot of people who aren't used to taking call for things like this. It's new. And every facility is different on how we address that. So, at one facility, they have a 24-hour person on call, and it's one set, let's say, phone number or pager.
Phone call, yeah.
Right. And so that's provided to the patient on discharge. And at a different facility, let's say some of our providers want to take ownership for any procedures that they do with continuous, nerve blocks or an epidural, where they are called for all of those issues. And the services are growing, as you can see, across our facilities. But again, we're highlighting this one in particular. And for this one in particular, our providers share the responsibilities of call.
Fantastic. Well, I would love to be able to dive deeper into this, because I think there are a ton of questions that we'd love to rack your brain on, because it is, a lot of people have a difficulty coming up with that value proposition for a full acute pain service, and have looked at it in the past and, saw a lot of barriers as far as like costs and things like that. So maybe we can catch up with you guys again later in the year and talk a little bit more specifically about that. But we just wanted to thank you guys so much for taking the time to discuss change with us. We all know, we've all been there and tried to, or done it ourselves. And so important to share those messages, because there are a lot of people out there trying to do it. And every little bit helps in creating this community and all this conversation around it. It is just so important. So thank you guys. And I applaud you. We applaud you for everything that you're doing. It's fantastic work.
So Desiree, one thing I thought you'd find this interesting is Dr. Sharma and I were talking, and this is, that's separate from the thing, right? Like, how do you know that you've changed culture? And we talked about it a lot. And we said, well, if you embark with a certain vision, certain objectives and goals and a tactical plan, you're going to see changes in some of the CMS data sets. So you'll be able to see that you established your goal. But if the goal is culture change, what we said was that if you start to see evidence that things are happening in areas you haven't done the education and training on, then it wasn't due to your education and training. It was due to something else. And in our opinion, that's when you've really achieved culture change. That it's not, something is happening somewhere else that you did not address on its own. And when you start to see those changes, you know that you've started to change culture, because something else drove that rather than something you intentionally embarked upon. Yeah. And it was something we recently talked about just in passing that I thought you would find interesting.
Yeah, absolutely. That is such a salient point there. So, well, we wanted to thank you guys so much for all the work that you're doing and sharing this with us on TopMedTalk, and your participation in EBPOM, Marc, was fantastic. We're going to be putting those conversations out on TopMedTalk over the coming months. So if you missed EBPOM in Las Vegas, you'll be able to hear all those wonderful conversations. So that's fantastic. And we want to thank you for listening to TopMedTalk and joining us today for this fantastic conversation. Please be sure to check out EBPOM at ebpom.org, or our new platform at live.ebpom.org, where you can find all the information regarding upcoming meetings. Monty, we got a couple. You mentioned one earlier.
Well, there's the ERAS cardiac meeting coming up, which is March 5th and 6th. And we'll be getting information out about how to register for that. Yep. And then there's as I said, the Welsh Perioperative Medicine Group, which is towards the back end of April, which is specifically a deep dive about where we stand on anemia management.
Yeah, fantastic. You can find all that there. And also for all of you, you can always find us on social media, Twitter, Facebook, LinkedIn. We are there. And for all the healthcare listeners who are out there listening today, thank you so much for all you do. Please stay safe. We know COVID is still going strong, and our hearts are with you. And we hope to see everyone sooner rather than later in 2021. So thank you. Oh, go ahead, Monty.
Well, the virtual London meeting, which hopefully some people will be able to come to London, but it'll be a hybrid meeting. So we're looking for people who's going to have the coolest fan zone. Southern California sounds pretty good to me.
I was just going to say, if you need a moderator out there in Southern California, happy to help. I'm vaccinated. And Marc, I'm sure that you will be having your fan zone up on the East Coast there.
Yes, we will. Thank you so much for everything and for having us. We're very lucky to be your guest, and thank you for all you do.
All right. And thank you for listening to TopMedTalk.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.